Welcome to Thursday Thought Leaders with Arvinder Narula on BW Healthcare World. As a part of initiating the global perspective, my guest today is Dr. Dimitrios Kafetzis, a respected gynecologist, a respected obstetrician, and someone who's known for his IVF treatment in Dubai as a part of the Orchid Fertility Clinic, Dubai. Let us speak to Dr. Dimitrios to understand the landscape of IVF and infertility treatments and the technology advancements, the impact that these technology advancements are creating. Let's speak to Dr. Dimitrios. It is such a pleasure, and after a long while of your meeting, while I met you in your office, it is a pleasure for me to have this conversation with you. So Dr. Dimitrios, infertility is a condition which is increasing multifold today, faster than ever before. What are some of the reasons you think that are contributing to this increasing need for fertility treatment today?
Harvinder, it's such an honor and pleasure to be with you today. Listen, I will try during this podcast to be as brief as possible in terms of giving you concrete answers. And in Greek, you probably know the Spartans through that movie, The 300 with Leonidas. Apart from being great fighters, because they were professional warlords, they had also another feature that you don't know. They considered a wise man a guy who spoke with very few words. So in Spartan culture, the fewer words you spoke, it made you look wiser in the rest of the community. So to go back to your question, two things are happening nowadays that didn't used to happen in our parents' and grandparents' time. The first one is that we are living to have kids at an older age. In the past, men used to have their first child when they were 19, 20, 22, 25. Nowadays, society, the social norms, what the teachers are teaching us in schools, the whole structure of society says, both for girls and boys, first you should be financially stable, then you should have a good career achievement, and then when you're 35, 40, then consider a baby, which is fine. Yeah, nothing wrong with that, but nature doesn't think that way. For nature, we should be having our babies at 20, 25. These are the best ages, like the best eggs, the strongest sperms, the least risk of genetic anomalies. Okay, so this is big important factor number one. Factor number two is what we all know, the environmental pollution. And by pollution, I mean everything, like the radiation from all the nuclear accidents we've had in the planet, the chemicals, the pesticides in the food, which actually never go away from the food chain. All these years like of pesticides, they're passing through the sperms, through the genes, from father to son. And now we see, especially with male fertility, because male fertility is easier to measure with a simple sperm analysis, we see from global studies of the WHO that actually men that were 30 years old 2 decades ago had stronger sperms than men that are 30 years old now. And why is that? It's not that we're not so fit, is that we're now living in cities with more pollution, more pesticides in the food, more processed food, less organic food. Remember how many times you were eating at your grandma's, like milk straight from the cow, or organic, like lettuce and tomato. Now you rarely can find this nice clean food. So these are the two main reasons.
What are the success rates in the industry as on date for pregnancy through IVF. I know they were around very, very low about a decade ago. But I think with technology advancement, we have improved. So what are the success rates today that we are claiming?
Look, with this answer, I can confuse you very much because the definition has changed over the years. And as I said in my introduction, we must not confuse our viewers. So, in general, we used to say per IVF cycle started, so let's say a couple starts one IVF cycle today, then it used to be in the year 2000, 25 to 30%. Now this has increased to 40, 50% in most of the countries in the world. So it has doubled, which is good. Intrauterine insemination, IUI, so the lightest form treatment, is about half of that, between 20 and 25% in clinics who really know how to perform intrauterine insemination and choose the couples. Lately, in the last 5 years, we're doing a lot of genetic testing for our embryos. So before we place them back in the uterus, we check, will this embryo give us a baby or not? Or it will be a miscarriage, or it will be a Down syndrome baby. So because we can do that now, the definition of success rate has changed. So now we don't measure success rate per IVF cycle started. We measure success rate per one healthy embryo transfer. And I'm using the term healthy a little bit out of context because we never know if an embryo will give us a healthy baby. But let's use the term genetically normal. So now clinics like us, per one normal embryo transfer, because now we don't transfer 2 or 3 anymore. If one is healthy, we'll put that one back. We have pregnancy rates of around 85%. Around 7 to 10% of these embryos will fail for other reasons that have to do with the mother, the uterus, the problems of the embryo that cannot be detected. So around 75% of times that we'll put in the uterus one genetically healthy embryo, this will give us a baby.
So, Dr. Dimitrios, you're absolutely right, and you spoke about genetic analysis, etc. So what are the other technology advancements that can be attributing towards the better success rates today? What are some of the innovations that you feel have happened that are contributing to this improvement of procedures?
Yes. The first one is the one that I just mentioned. And I will put this into context. The genetic testing of the embryos for IVF has been something that we had always longed for. And when it became a reality around the year 2000, then everybody thought, okay, now we'll get 100% IVF success rate. It didn't quite work, but we're getting there. In the past, to tell you how important this is, in the past, you know that we were transferring 2, 3, 4 embryos in the uterus of the woman, hoping that one will stick. This led to a lot of multiple pregnancies. And okay, when twins are born healthy, perfect, they're a blessing. But when they're born premature, which is something like 10 to 20% of times globally, then these babies may end up with brain problems, bowel problems, mental retardation, autism. And then instead of becoming a blessing from the family, for the family, they are a situation where it's not what couples were dreaming of. What I'm trying to say is that the genetic testing of the embryos still is not perfect, still is not 100% accurate. It's like over 90, 95% accurate, but it has saved couples from a lot of miscarriages, a lot of extra costs that are not needed anymore, and a lot of twin pregnancies that didn't end up well. So I'm a big fan of that. And imagine that in our clinic, we are promoting now a genetic test that tests the embryos without touching them. because one of the arguments that doctors use when they don't like this genetic test is that, by taking embryo, you affect the potential to produce a baby, which is partly true to a very small percentage, which cannot be quantified. So now we're trying, we need this test so badly that we're trying to discover new ways of testing the babies before we put them in the uterus, but without taking any cells, just from the fluid around the baby. This is a new advancement that it's becoming, in our clinic, we're doing in a research level, but it's becoming available slowly, globally. It's still not there, but it's getting there. The other big advancement is that has helped improve the success rate is something to do with the lab, the embryology, and that there has been many small and big changes over the last 20, 30 years. For example, now we have incubators, like the little boxes that we put the embryos, the babies in, that because we have cameras on top of each baby, like Big Brother used to be, we don't have to take them out of the nice warm environment every day to look under the microscope. We can look at them even from our mobile phone through an app. And that is good because they're exactly like the mother's tummy. They don't get disturbed. They're always 37 degrees. Okay, so this has helped produce stronger embryos. Of course, again, we are not exactly there yet, but it's a step in the right direction. And we have other methods like choosing the best of the best of the best of the sperms. Choosing the best ones usually comes with better DNA, usually comes with stronger babies in the end. All of these things together, and if I had to add something, I would have to add now the fact that before we put any embryos in the uterus, we check the uterus with a camera procedure called hysteroscopy. In the past, for this, we used to use anesthetic, but now we can do it in 10 seconds because the cameras are becoming very thin, like the cameras in the spy movies that you see. Right. So women feel almost zero discomfort or discomfort for 10 seconds, and then they go back to work. But we have checked, I call it the first baby room, that we're going to put the baby inside. We checked it. So we have excluded scar tissue, polyps, fibroids, infections, anything that will stop a good baby from implanting. So all of these improvements together over the years, the last one is called office or outpatient hysteroscopy. All of these together, slowly, have increased the pregnancy rate. It has been a 20, 25-year process, step by step. It doesn't happen overnight.
Okay. And Dr. Dimitrios, before I go to the next question, can you put your phone little up?
Yeah.
Because I'm unable to see your face. Dr. Dimitrios, since we're talking of technology and you've spoken about genomics, you've spoken about the cameras to test the uterus, etc. A lot of development is happening around the use of AI, artificial intelligence, every field of healthcare. Are we using AI in some way when it comes to infertility treatments? And if you can share some thoughts on how you are using AI and what is the improvement that we have seen by using artificial intelligence?
Yes. As in every field of our life, it's coming into our fertility field as well. The main two parameters are one in the lab, the embryologist side, and one in the doctor side. Now, the embryologist, it stems from the biggest question we have. How can we pick the healthy embryo without touching it, without disturbing it? Here comes AI because in collaboration with the camera, as I've told you, they can compare pictures of millions of eggs, millions of embryos, something that one person or a team of people would never do, but computers, with their processing power, they can do, and tell us that if an egg looks like this, the chances of a healthy baby are this high. If an embryo looks like this, don't test it. It's perfect. It's going to give a healthy baby with a percentage of 90-something%. Again, it's a new technology, it's improving, but it will help us. And studies are coming daily on this. Like every journal, every month, a study about AI is there. Improvement of selection of the sperm. Also, like how do we choose the best sperm? We cannot cut it open to check the DNA. We have to check just by looking at it, how it swims, what's the shape. This is the lab part. So the whole idea is to learn about eggs and sperm and embryos without touching them. And artificial intelligence gives us huge power of processing. On the doctor side now, when we give the hormones to women to create more eggs, the honest answer is that no doctor around the world knows what is the best dose for each woman, what is the best hormone out of the 4, 5, 6 available for each woman, and how this woman will respond in these hormones. Now, when artificial intelligence managed to put into the supercomputers something like 5, 6, 10 million stimulation cycles, all the data, then at some point an outcome will come to say, when a woman is 32.5 years old, with these AMHs of ovarian reserve, with this actual number of eggs in the beginning of the stimulation, then give her this 200 units of hormone, and she will produce the perfect number of eggs and embryos. So maximizing her pregnancy rates. This is what we expect from the doctor's side. And there are other ideas that I personally have, and many doctors, on how to use artificial intelligence, but I think that the everyday life and everyday hard work doesn't allow us time to think about it or implement them. But as you know, the potentials are huge. We need data, and AI will come with that data comparison and categorization and guidelines, I'm sure, and very soon, within the next 1-2 years, I expect.
And Dr. Dimitrios, when we started the conversation, you mentioned that one of the reasons of fertility issues is because people are wanting to get married late. They want to have babies much later in their life.
Yeah.
Now, how is technology helping towards the fertility preservation? For example, the embryo freezing it, etc. So how is technology making this possible today, and how much have we succeeded?
The embryo freezing and defrosting, I dare say, although we have like Einstein said, like you open one box and then 1,000 other questions arise. So in my words, so the fact that clinics with strict protocols of freezing and defrosting embryos, they get 100% thawing rate, so no embryo dies, or less than 1 in 1,000 of embryos that we defrost die on defrosting. I'm using the term die. You can say they don't thaw, but to make it easier for the people who listen to us who are not medical. This means that at least on the survival of the embryos post-thawing, we are okay. Still, these embryos are not as good as fresh. So still we have steps there. But where we could make even better progress is the egg freezing and defrosting, because that's the true fertility preservation, correct? Like we would like to say to a woman when she's 22, look, here, freeze 15 eggs with us so that you have 100% pregnancy rate if you need those eggs when you are 40. Still, we're not there, because according to different age groups, the older women get, the less eggs will defrost, and the less of those will become healthy babies. So we are not there yet. We need to improve, in the fertility preservation in terms of egg freezing and sperm freezing. We're in a good position. We're much better than 10, 15 years ago that these techniques didn't exist. But at the same time, we have to improve the techniques much more.
And Dr. Dimitrios, fertility or infertility has been a taboo for many years. In fact, there's a confusion and there's always a myth that the problem always is with a woman. And especially in our societies, that is more prevalent. How do you, in your practice, create awareness towards sending out a message that it's okay to go in for a treatment if you're unable to become pregnant naturally, and also sending the message that, have a male tested too, because many of the fertility cases or infertility cases are because of the male infertility. So how do you, in your practice, create this awareness and help people get over this mental challenge of accepting the treatment options?
Yes, you're very true. It is a taboo in all societies. In some societies, more than others. I can tell you now through global studies that male factor infertility, in other words, when it's the sperms that are not strong enough, is actually now a higher reason, a more prevalent reason for fertility in terms of like 55-45. So 55% it's the sperms and 45% is the eggs. Now that's global. It didn't used to be the case 10, 20 years ago. I think there the internet has played a bigger role over the last decade, because now every couple will go online and will see those numbers. And then while they talk to each other, oh, we can't have a baby, could it be me, could it be you? Then they will go online and say, actually, yes, it's not only the woman. And they will go to the fertility clinic and get tested. That's, I think, what usually happens. Now, what we try to do with our podcasts, with our everyday posts on Instagram, we are stressing out that it's not one person to blame or another person to blame. It's not a blame game. It's getting a baby. It doesn't matter where the problem lies. So we prompt couples to come in and get tested, especially 1 month a year. I think it's November. It's the male infertility awareness month. So we give out free semen analysis for couples to come in and the men to get tested. So even single men can come and get tested during that month. But the semen analysis costs very little. And the results come out immediately in a couple of hours. So we email them and the man immediately knows there's a problem, there's not a problem. And the good news, the problems with the sperm is most of the times fixable. Like sometimes it's a hidden infection. Antibiotics improve the sperm. Sometimes it's these varicose veins that are dilated and overheat the scrotum, the testicular area, and we operate on them in a very small operation, and the sperm improves and couples get babies. Sometimes it's just stopping smoking, lifestyle, losing weight, going to the gym, and stopping alcohol. So these are the factors that we can improve.
And Dr. Dimitrios, this is very interesting. In how many cases do you think of the people who come to you, are you able to help your patients get over the infertility issue without actually going in for an IVF treatment?
We have calculated that. The answer to your question is around 10 to 15%. I'll give you numbers. 3% of couples that see a consultant just for a chat, they will get pregnant at home, naturally, as we say. How will that happen? The doctor will tell them how to improve their lifestyle. The doctor will tell them which part of the month they should be trying, because not all women have regular cycles. Not all women release the egg exactly on day 14. Only with a quick chat with a couple, we can teach them. Some couples have difficulty having intercourse because of pain, erectile dysfunction, which is curable. Okay, so without doing any intervention, just chatting helps 3% of them get a baby at home. Also, we can do milder interventions. Like, for example, women with polycystic ovaries, they have one big problem. They're not producing eggs. They're not ovulating. But with tablets or with tiny, tiny dose of hormonal injections, we can induce that, monitor with a scan, tell them exactly when the egg is ready, and tell the couple, now is time to try. What we call timed intercourse. And it happens, especially for younger couples, it's very successful. And also before IVF, escalating now a little bit the treatment, we have the more natural approach, which is called intrauterine insemination. So we choose the best sperms, put them in the uterus at the right time of ovulation, and give extras for helping the baby to stick. And then before we reach IVF, we have actually cured 10 to 50% of the couples. And actually, I always use this line. Curing a couple like this makes us better doctors because we follow what they taught us in medical school. Here is the problem, diagnose the problem, treat the problem, and get the outcome, the baby. So this, like IVF, of course, helps, but many times it's bypassing the problem. We have a sperm problem. Let's not try to fix it. Let's do IVF. It's okay. When it works, everybody's happy. When it doesn't work, couples will come to us and say, doctor, you didn't test me properly. You didn't give me vitamins. You didn't tell me to stop smoking. And I read online that stopping smoking actually improves the pregnancy rates. And these are the stories that you hear that, oh, this couple did IVF, they failed, and then they got pregnant naturally.
No, it's a very beautiful point that you've brought out, Dr. Dimitrios, because, sometimes you have to identify the cause for infertility and solve that than working on the symptom or the outcome of a problem.
Let me make a point there. Many couples come to us very stressed because of the family putting pressure, because of the women thinking, oh, I'm old now, I'm running out of time, etc., etc. And they want treatment, the most successful treatment, immediately, right there and then. Okay, so this puts us on the spot, because imagine telling a couple, well, I'm going to prescribe some investigations. I don't know if they're going to show something. I don't know if you're going to get pregnant after those. And in the end, you might end up doing IVF. And then they say, doctor, you're just delaying me. Let's do IVF. But it's up to the doctor to explain, talk. And together, we find the best plan. Because if we as doctors succumb and say, couple want IVF, let's do IVF, it's good for everyone. Sometimes it's not good for everyone. There is pressure and we cannot oversee. The point is to go back to what I just said earlier. Don't leave babies for too late. Start early, think early. Don't put career first.
I think that's the duty of the doctor, and also the ethical responsibility for the doctor to explain to the patients the right thing to do. A pressing point when it comes to choosing the right doctor to go to is the question of the affordability as well. Now, there are different clinics charging very, very different costs for the treatment. So can you explain for the benefit of the viewers what steps are there in IVF and what are the areas where there's a cost involved? Of course, in India versus Dubai, the cost is going to be very, very different. But if you know that these are the things that you'll need to do, and this is where the cost will be there. And also, if you can explain, how should a patient choose the right doctor to go to?
That's a very good question. That's a very good question. I will try to make it simple. Sometimes in all areas of life, including medical treatments, including fertility, what you pay is what you get. So if a clinic has high success rates, good feedback online, and then please, I'll say to the couples, check the online groups that are independent, not an online group that I can go and advertise myself for the fake profile. So if a clinic has high success rates, if other couples got pregnant in that clinic and they recommend that clinic, even if that clinic is more expensive, they must be doing something right. They must be doing something right. On the other hand, not everybody can afford a successful clinic. So there it is a little bit of a balance. But my recommendation is always this: if you choose a clinic with high success rates, maybe you will actually be able to succeed first time and not the third or the fourth time. In that context, you might end up paying less than what you pay, like if you go to a clinic that doesn't pay so much attention into detail. That's the gut feeling that I have, and that's how I've been working all my life. Why is such a variety of prices between different clinics of the same country? The variety is not so high. Clinics that are more expensive, what do they usually have? They have better equipment, and they have better quality doctors, nurses, and embryologists, and they do more tests. So they investigate deeper. And that's why they're probably even more successful. They pay more attention to detail. Okay. Clinics that are cheaper, usually they have cheaper equipment, and they try to reduce their costs by giving different quality medication or doing less tests, bringing the couple less time, less visits, so that the profit margin remains somewhat high, so that the clinic can make some money as a business. So that's what I would prefer: a doctor who wants to see me every day to tailor my treatment, like we go to the tailor to make our suit or to make a dress. The more times we visit, the more perfect the dress will be. It's kind of the same. In other words, we call it the doctor's attention. If the doctor pays attention every time, okay, he will charge more, but most likely it will work better in the end. So, and then of course, between countries, like the third part of your question, there's other factors. For example, salaries in Dubai, much higher than salaries in India, or even the salaries in Sharjah or in Ras Al Khaimah. The rent's the same. The rents are much higher for a clinic in Dubai than a clinic in other Emirates or a clinic abroad. And even the cost of the medication. Many couples say, doctor, I'll bring the same medicine from Greece. I'll bring the same medicine from India. It's okay. If they properly store the medication and somehow they can bring it, of course we'll accept it. There is a problem if they put the medication on the plane and the temperature is very high and then it doesn't work. But the different countries, much of the medication in India is produced there, so much cheaper. Here in Dubai, we have to import everything, much more expensive. So this increases the cost of the treatment. These are the factors between different countries.
And Dr. Dimitrios, what are the possible causes that lead to a failure of IVF treatment?
The biggest factor that we cannot fix, or science has not found an answer yet, is how to improve the quality and the chromosomes and the DNA of the eggs and the sperms. Like, in other words, we call it in philosophy, we call it the elixir of youth. So when a woman comes and she's over 45, 46, 47, it's extremely difficult to give her a baby with her own eggs. And for men, the same. It's not like we used to say, oh, men can have a baby until they're 70. No, we see sperm swimming until they're 70. We see millions of sperms, but they're not as strong as when we were 20. So AIDS is something we cannot reverse yet. We are looking into it. Science has now, the scientists in the lab have produced sperms from stem cells, and they're very close to producing human eggs from stem cells. We're a little bit away from making it applicable on everyday life to say to someone, I'll take your bone marrow, make it into an egg, and it doesn't matter if you are 50, you're going to have your baby. Eventually, it's going to get to that. And it will not matter anymore, like how old you are. But for now, this is our biggest problem. This is our biggest problem.
And Dr. Dimitrios, does IVF affect the overall health of a lady? Are there any lifestyle changes that a woman is required, or have we advanced to a point where they can lead a normal life?
I think that question has two different answers. One is, and couples, this is one of the very hot but also long-term questions. Couples say, doctor, you're going to give me, or the husband asks, you're going to give my wife all these hormones for IVF. Is she going to get cancer 10 years down the line? Any cancer? The answer is most probably not. All the studies that come out, with the latest coming from the American Society of Reproductive Medicine, that summarized all the studies globally that were looking prospectively in women that did IVF many times, not one time, many times, they said that actually we don't believe that it increases the risk of cancer of the breast, the risk of cancer of the ovary. There are some asterisks there, but very, very small and under investigation. And we're talking millions of cycles. If there was something, it would have shown up. And these are independent studies, country studies, not like one clinic or two clinics. So that is a little bit reassuring. The second part, how a woman feels during an IVF cycle, it is like I always say to my couples when they see me, it's difficult. It's not a walk in the park, but it's not hard surgery either. It's something in between. So the 2 weeks that we give hormones until we do the collection of the eggs are tricky. So bloating happens, headaches, mood swings, and the operation, it's a small operation, but it's an operation, needs anesthetic. You cannot go on the plane and travel the next day or the same day. So we ask them to be careful, take a rest for those 2 weeks. After that, especially after the period comes, after the egg collection, women feel back to normal, especially after 2 months, completely back to normal. So all these fluid that they're telling us, doctor, I feel puffy, doctor, I gained 3-4 kilos, it's just water from the hormones. It will go away. It will go away. Especially if they're a little bit back into their exercise, they will feel back to normal. And that's why some women need to do IVF every 3-4 months, every 2 months. They're okay. They don't get side from doing that. Okay, so it's not easy, but it's an IVF cycle doesn't have any long saying side effects, weight gain, or like affecting the mood permanently. Imagine the drugs stay in the system for 1 day. That's why we need, the body burns them. That's why we need to inject every day. Otherwise, we'd inject every 5 days.
And Dr. Dimitrios, one of the questions that I have received from a lot of people when it comes to IVF is that they fear that the chances of miscarriage are more if a lady has become pregnant using IVF as a technology. Is that a
Yeah.
myth?
This used to be the case, yes, before genetic testing. After genetic testing, we see less and less miscarriages because these embryos are the chosen ones. They are tested already for miscarriages. Still, after genetic testing, the miscarriage rate is not 0, but is around 5 to 7%. Whereas without genetic testing is around 30%. So in other words, with IVF, the classic IVF, or when a couple gets pregnant naturally, the moment they see the positive pregnancy test, 70% will be a baby, 30% will be a miscarriage at any point of the pregnancy. So, of course, changes with the age. I'm giving you broad numbers. So the answer is yes. The classic IVF with genetic testing has a high risk of miscarriage, but this is something that the genetic testing of the embryos has reduced, narrowed down to something like 5 to 7% per embryo transfer.
Dr. Dimitrios, I have one more question before I let you go. And
Yeah.
that is similar to, when we're talking of the lady who has gone through an IVF, we're talking of miscarriage. But we also understand that using technology, when we're using AI, genomics today, we are able to test the future of the baby that we are going to produce. And are we able to find out conditions such as Down syndrome or possibility of a handicap or anything at an early stage? And what do you do or what do you think is usually done in such cases where we have been able to identify such chances which could be bringing up a troubled baby?
That's a good question. Yes, and because it comes up every time that that a couple asks us about genetic testing, it's very important for the doctor to explain, and also the medical leaflets, the information leaflets that we give to couples, to be clear about that. Because the moment a couple do IVF, and especially if they do genetic testing of the embryos, they think that, oh, the doctor told me the baby is normal, so everything will be absolutely fine. Unfortunately, science is not there yet. The good news, the genetic testing of the embryos predicts Down syndrome over 95, 96, 97% of times. And then the moment the couple get pregnant with an embryo that has been tested, we have I call it the double safety net, like the circus when the acrobats do the trapeze, that they don't fall down, but they have the safety net. The second safety net is around 10 weeks of pregnancy, so the first 3 months, where we can do the blood test of the mother and see that the baby doesn't have Down syndrome, plus other mental retardation problems. We call them microdeletions. So at the embryo stage, we can test many things. At the 3 months, we can test even, but it's very important to say to couples, don't miss the 3-month test. It's very important. And also, don't think that because we tested the embryo, everything will be 1000% fine. For example, the genetic testing of the embryo cannot predict structural anomalies like a heart valves problem of the baby, cannot predict autism, which is a severe, can vary the spectrum from very mild to very severe disability. And sometimes it's genetic. most of the times it's not. But for the couple, this is like small print. What they want is, doctor, will my baby be healthy? Will my baby be normal? Will my baby be absolutely fine? And the answer is, the more genetic tests we do, the more chances we have to predict early. But science needs another 5-10 years to eliminate almost everything at the pre-transfer and at the 3 months. I believe in something in the next 5 years, we will be able to say to couples, yes, everything will be absolutely fine. We're not there yet, but it's getting there with genetics and genomics, as you say.
Dr. Dimitrios, it has been such a pleasure speaking to you. It was pleasure when I met you, but this conversation is very, very meaningful. And it's so nice to see the development that is happening with technology advancements today, where we are not just creating more success rates. We are able to identify a healthy embryo. We are able to do one single transfer rather than putting multiple embryos that are resulting into multiple babies. So it's much safer for the mother as well. And second, I think you brought out a very beautiful point when we spoke about how do you find a good clinic, how do you choose your doctor, and why would probably one clinic be more expensive than the other, where you stated that, one, the experience of the doctor. Second is, maybe the clinic is well equipped, but the quality of equipment that they may be using could be very, very different. And third is, we are talking about the number of investigations, the ability of a doctor or a clinic to go deeper to be able to create a better success rate for you. So, so these are the three things that you must look for when you are choosing the doctor that you choose to go to for creating something which could be a valuable gift for the rest of your life. So, Dr. Dimitrios, that's a beautiful conversation. I love the way you have explained it. It was very, very clear and, something that could make sense for a layman and not just somebody who understands the technical terms. So thank you so much for taking out time to speak with us. And I will look forward to many more conversations with you over these topics.